Hello, my name is Randy Kojima, and it's my pleasure today to host this webinar on Orthokeratology Topography. Basically, what we want to discuss is how does the topographer fit into practice, both pre and post-treatment, when we're fitting orthokeratology patients? Before I get started, I wanted to acknowledge Medmont and the Medmont E300 Corneal Topographer as a sponsor of this session. The Medmont Topographer is regarded as the gold standard in specialty contact lens topography and specifically orthokeratology application. So the first question I wanted to ask was, could you practice Ortho-K without a topographer? Is a slit lamp and a vision chart all we need for the assessment of an orthokeratology fit or outcome? Let's pick an extreme example. Here's a patient with absolutely normal K readings. Flat K of 4291, about 43 diopters or 785 millimeters, and a moderate amount of astigmatism, 1.64 diopters. Picture in your mind what that topography might look like. If we showed you this topography as associated with those K readings, would that make sense? And the truth is, these are the K readings associated with this topography. So K readings are of relatively limited value, especially in the irregular cornea, but you can imagine post-treatment, if we're trying to assess what we've done right or what we've done wrong, K readings are not going to be the big picture. We need much more data, and that's what the topographer provides, both before we start to help us choose the right initial lens and after we fit to determine modifications that might be necessary. K readings, of course, give us such a limited area of the cornea, 3 millimeters of the center. They give us nothing inside of 3 millimeters. They give us nothing outside of 3 millimeters. So if we're fitting a 10.5 corneal GP or an 11 millimeter Ortho-K lens, we're missing a lot of corneal data to be able to construct our lens. Soft lenses clearly don't require topography in their fitting, but could we fit a higher percentage of patients or have a lower dropout by understanding eye shape slightly better? And certainly for scleral lenses, understanding as much of the cornea is going to help us to fit those bigger diameter lenses. So again, without topography, could a slit lamp and a vision chart get us through an exam, get us through treatment, and help us to achieve success? So let's take a patient that had a fluorescein pattern that looked acceptable. The comfort both with the lens on and overnight was okay. The vision in the AM post removal was +1/4 and 6.6 minus vision, but in the afternoon the vision was quickly sliding, and in the PM the patient was noticing aberrations. So what seems to be the problem? Is the treatment zone too small? Is the treatment zone decentered? Is the effect wearing off too quickly? How do we know what the problem is here when we're only able to assess the lens in the open eye environment, which is not where it works in the closed eye environment? And second, how do we know what's going on with the power of the eye other than to say this patient's vision is dropping? This is where topography is so critical. Here's a good example where the patient had in the center on the visual axis a 2.2 or about 2.25 diopter refractive change. But that treatment zone is riding very high, and we get this paracentral steepening inside the pupil. So this is why the vision is fading very quickly, because number one, we haven't centered the treatment zone. Number two, we've got this large steepening in the neighborhood of about 3 diopters inside the pupil. So topography is so critical to us, both pre and post-treatment, to help us through the process. And if we're not sure about the fluorescein pattern and we're thinking about dispensing the lens, what if you're not sure? What if you're not 100% comfortable with fluorescein analysis because you're new to Ortho-K lenses? Or what if you're a new practitioner to eye care and fluorescein isn't an area that you're so comfortable with? Well, this is where topography can be very helpful. Once you actually fit a patient, you have your pre-treatment map, your post-treatment map, and your difference or subtractive or comparison map. And this tells us many things about what happened after Ortho-K. Number one, the axial map tells us the treatment zone position, looking at this blue border and where is it in relationship with the black pupil. We can say this lens is centering exceptionally well. The blue treatment zone, the effect is well centered to the pupil. Number two, we click our cursor in the center, compare the power of the eye before Ortho-K to the power of the eye after Ortho-K, and there's a 2 1/4 diopter RX change. So we don't have to do a refraction. The topography will tell us if we have a good baseline and a good post-treatment map. The axial map will tell us about vision. Then we use the tangential map to understand where the lens was positioned in the closed eye environment. So this red ring is used to determine where the lens is positioning in the closed eye environment. Is that red ring well centered to the black pupil? And it looks like it is. So both the axial and the tangential are saying we have a quality centration of our treatment. So if you're not sure about fluorescein pattern, if you think it might be acceptable or you're uncertain, then just send the patient home with the lens and let topography prove things out. If we have a good fit, we get what's called the bullseye. If we have a flat fitting lens, a high riding lens, we get what's called the smiley face. If we have a tight fit or a low riding lens, that's called a central island. So topography is going to tell us everything about the outcome. Now, if you look at this topography, could you make predictions based on centration or effectiveness of treatment? Is there something in this topography that would indicate to you where the lens might center? And you might look at this green-blue border. This is the peripheral cornea where our lens will land. And is it somehow displaced in relationship with the visual axis or the pupil? And I would argue that this is a pretty symmetric eye. So I'm thinking before we start Ortho-K that I should be able to center an Ortho-K lens pretty well on this cornea. In other words, this cornea should be fairly forgiving and we should be able to achieve decent centration if our specifications of lens are relatively close. And sure enough, when we did Ortho-K on this patient, we get this beautiful treatment zone well centered to the pupil. So because our baseline corneal shape is symmetric, then we expect our lens to want to land on that symmetric peripheral cornea and be centered. Now, what about on this eye? Do you see anything in the appearance of this topography that might indicate the lens should want to decenter or should it be centered? And sure enough, if we look at how the contours seem to be pulled down and out on this left eye, that's where the treatment zone follows. The lens follows the natural displacement of eye shape. Baseline cornea down and out, treatment down and out. So this might be as good as it gets for this patient. If this doesn't provide quality enough vision, then it may be this is the best that we can do for this patient. We would, of course, try to loosen up the landing zone or alignment zone of the lens, try to bring it up a little bit, so loosen it up since it's riding a little bit low. But if that doesn't do anything, then we know we're simply fighting nature. Another consideration before we start Ortho-K is the appearance of the astigmatism. Is it apical? Is it confined to the center of the eye? Or is it more limbus to limbus, where it stretches from one side of the eye to the other? Because these two eyes are very different in the way contact lenses fit on them, and specifically orthokeratology. So if we do Ortho-K on a nice apical astigmatism, a nice confined figure 8, then you notice you can sphericalize the vast majority of the pupil. You can squeeze out that hot meridian and eliminate the vast majority of the astigmatism. Notice this patient started out with 1 diopter of corneal cyl. Post-treatment, only 0.1 diopter of corneal cyl. So we've been able to eliminate 90% of the corneal astigmatism, and we've got a beautiful bullseye, a nice centered response. When we fit Ortho-K lenses, symmetric lenses, on limbus to limbus astigmatism, it's a little trickier to align the lens out here and create the appropriate hydraulic forces. And that's seen in the shape post-treatment. That figure eight appearance is still there. We haven't moved the astigmatism out of the way. So this patient had 1.5 diopters of pre-treatment corneal astigmatism. Post-treatment, it's actually increased. We've flattened the cornea out centrally, horizontally, but done nothing to change the shape of the eye vertically. So our corneal astigmatism has actually gone up, even though it's a well-centered bullseye. So limbus to limbus is a slightly tougher Ortho-K case. It may require toric Ortho-K lenses. Now the capture process is critical, as you would imagine, especially pre-treatment. The first topography that we take determines the initial lens that we place on eye. The more accurate the initial lens, more likely, the more accurate our outcome. So spend the time on the capture process. One of the things that is we need to consider is the fissure size. So getting the lids out of the way. But it's not just the lids. The eyelash shadows come down, create these reflections on the surface of the eye, and block much of the reflection to the cornea. So we learn very little about the astigmatism along the vertical meridian, assuming it's a width the rule patient. What is the shape of the eye up here and down here? We need to get this fissure size open so we can get much better data. Let's get the patient to open up as wide as they possibly can. That way we can have a better understanding of this eye shape, not just across the horizontal meridian, but also across the vertical meridian as well. Make sure you zoom in to determine if those rings look parallel and even, if we have nice ring reflection across the surface of the eye. Now, another consideration is tear film breakup. Do we see parallel and even rings? Do we have smooth and even tear film? Or do we have areas where the tear film distorts and breaks up? And in this case, we see this beautiful reflection, all the rings centrally especially appearing smooth and parallel with each other. And that creates this topography where we have steepest contour all the way to flattest contour with this very gradual change in curvature. All the contours themselves are well-rounded and smooth. And that tells me that it's likely that this is an accurate interpretation of eye shape on this very normal eye. As you know, normal eyes are very smooth, so we would expect our topographies to show similarly smooth transitions from steepest to flattest. But it's impossible to say from one capture if it's accurate, and that's why you use multiple captures. That way you can determine if there's reproducibility. Are the maps the same 4 times over? And in this map, we see this severe hotspot that doesn't appear on the other maps. We see the rings beginning to run kind of vertically, and that's where the tear film is welling up and the topographer's placido reflection is reflecting off that lacrimal lake down there, giving us a false steep spot. So if we'd begun treatment with this one single map, we may have been heading in the wrong direction. This one here seems to have a bit of a flat spot in the center. So is that tear film breakup? All these maps look different. There's no reproducibility of the topographies. So we may need to take more maps and determine if we can get better reproducibility, so better quality of capture. Here you see 4 images that look identical. Every one of these shows a very similar appearing topography. Beautiful figure 8 shape, smooth contours. So when we calculate our initial lens, we're doing so with greater confidence in our baseline data. So 4 captures is the minimum number of pre-treatment maps that you want to take. If you happen to have the Medmont Topographer, then you can do what's called a composite map, which images 100% of the visible iris. So that gives you multiple maps merged together to fill in all this peripheral corneal shape. The way it works is you take a central image, patient looking down the axis of the instrument, and then you take your photo. Then you'll have the patient look nasal, look temporal, look inferior, look superiorly, and push those rings to the peripheral cornea. In other words, you're pushing the placido out toward the far periphery of the eye, and then you're able to fill in 100% of the corneal shape. So rather than having the patient look down the axis of the instrument, we have them look 1, 2, or 3, 4 rings nasal, then 1, 2, 3, 4 rings temporal, then 1, 2, 3, or 4 rings inferior and superior. It may only be one ring if the angle kappa or angle lambda is low. However, if you can't push the rings to the peripheral cornea, then have the patient fixate another ring. So rather than one ring, go 2 rings. If that doesn't push it down to the bottom or the extremity, then go for 3 or 4 rings. Now, once those maps are taken, they can be converted into a topography, and those topographies can all be merged together to create a larger view of the eye. And that's what's called the composite feature, available in the Medmont Topographer. And that gives us the largest area of understanding related to our Ortho-K lens. For instance, on this patient, we're getting over 12 millimeters of data. If we were designing an 11 millimeter lens, we would have plenty of peripheral cornea to be able to estimate the true parameters of lens we need. Now, a question that you might ask is, what's the most important topography that we take? Is it the pre-Ortho-K map or the post-Ortho-K map? And consider that we will never have another baseline again. Once we begin a patient in Ortho-K treatment, they have an altered corneal shape. And that corneal shape may have some fluctuation from visit to visit, but for the most part, we're not seeing the true baseline shape unless we wash patients out of Ortho-K. So it's important to have a good understanding of the pre-Ortho-K topography, because we are going to compare every visit in the future to the baseline. So the first map is the most important. And of course, the first map determines our initial lens parameters. So that makes it absolutely critical to have quality readings. You're always going to have another post-treatment visit, but you will never have another baseline pre-Ortho-K map unless you normalize the cornea, which could take months. Now, when you receive your corneal topographer, whichever brand it is, one of the first things you want to do is adjust the scale. In this case, we have what Medmont calls a K scale, which goes from 9 diopters to 100 diopters. But this patient has curvature that is ranged only between 1, 2, 3, 4, 5, 6 colors. So this small little range in here. In other words, we're missing so much of the definition of the eye because our scale is much broader than the range of curvature of this eye. If we adjust the scale to a normalized scale, now we understand the steepest we can read ends up the number at the top of the scale. The flattest we can read is the number at the bottom of the scale. So the scale shifts in normalize specific to the eye that you've selected, giving you much more definition. The benefit of the absolute scale is if the eye pops up all red, you know it's abnormally steep. If the eye pops up all blue, you know it's abnormally flat. But it doesn't give you much definition, and that's why the normalized scale is best to appreciate. Is it an apical astigmatism, or is it limbus to limbus, as an example? Now, when you get your topographer, you have a number of different analysis options. Which one do you use? There's so many options. These are only a few. Which ones would we use for Ortho-K treatment? And all of our functions that we do in eye care. Well, to understand the power of the eye, to understand how the cornea might might affect vision, you would use the axial map, which in some topographers is known as the sagittal or power map. The axial map helps us to appreciate, is it regular corneal astigmatism or is it irregular corneal astigmatism? When we take the pupil and cut it in half, is this side of the hemisphere a mirror of this side of the hemisphere? Is this side a mirror of this side? Is this a symmetric eye that can be easily corrected with spherocylinder refraction? When we take this patient, we can't cut this into hemispheres in any direction. It's a completely asymmetric surface. So we would expect this patient would require some kind of rigid lens optics, some kind of GP lens optics to provide a high level of acuity. Now, the tangential map is used to understand shape. Where is there a radical point of curvature change? In this case, in this pellucid marginal degeneration, 1 square, 2, 3, 4 squares from the center, or 4 millimeters from center, that's where the eye begins to form this very radical curvature change. So if you want to measure the size of the cone, the position of the cone, you would use a tangential map. If you want to see if you've molded the cornea, you would use a tangential map. Now, if you want to understand the height and depression in the eye surface, that's where you use an elevation map. An elevation map will tell you where the cornea is high, that's the red, and where the cornea is low, that's the blue. So where would a contact lens bear on the surface of the eye? Where would it lift? And so that's where the elevation map becomes beneficial. Now let's look at these eyes another way. We've looked at K readings, we've looked at eye shape, we've looked at axial versus tangential maps. Now let's look at these eyes in terms of height. And if we concentrate on where the K readings would be taken at around 3 millimeters, we see these patients have very similar central corneal shape and central corneal sill. This patient has 1.59 diopters of corneal astigmatism. This patient 1.47, slightly lower, but both around 1.5 diopters of corneal sill, or 0.3 millimeters of corneal astigmatism. But what's the difference between these eyes? Here you see 360 degrees almost of green. The peripheral cornea is spherical. But here we see the lateral sides green, but running from 12 to 6 o'clock, we have the steep meridian, or limbus to limbus astigmatism. When we look at this eye, not in terms of central corneal sill, and not in terms of the appearance of the peripheral cornea, what if we measure the height of the eye? And across the horizontal meridian, this eye measures 1466 microns. Across the steep meridian, 1489 microns, or a difference of 23 microns. So this eye is much deeper running vertically by 23 microns. Now that's a fairly low figure. It's significant, might be 40 or 50 microns of difference between the depth of the eye this way and the depth of the eye this way. In other words, a symmetric Ortho-K lens should work rather effectively because the peripheral cornea is not so toric. However, when we look at our limbus to limbus astigmatism, now we see a patient that has a defined flat, defined steep, but a much more toric periphery. So let's pull up the flat meridian sagittal depth, the steep meridian sagittal depth, and look at the difference. And now we're up at 45 microns. So these eyes are significantly different. Our apical astigmatism has a less toric peripheral cornea. This patient here, a much more toric peripheral cornea. This one would work much better in a symmetric Ortho-K. This patient will most likely require some kind of toric landing to create better fit, better comfort, and better hydraulic force and effect. Now, when we fit that apical astigmatism, we're able to center our lens very well. We're able to squeeze out that astigmatism and create a more sphericalized central cornea. We're able to create a beautiful effect. When we fit a symmetric lens on a limbus to limbus astigmatism, we may be able to achieve a nice bullseye, but can we squeeze that cylinder out of the way? So an important consideration for both fit and hydraulic force. Can we produce the high enough hydraulic force to push that astigmatism out of the way? So this is one of the simple things that you can do pre-treatment in addition to looking for corneal displacement. Is the eye decentered one direction or the other? Look for whether it's apical or limbus to limbus. Should you be starting with symmetric or should you be going to toric? Now, one of the reasons why the apical astigmatism is so easy, as we discussed earlier, we're relatively symmetric in the periphery, and that gives you an ability to land almost 360 degrees around. When you have your limbus to limbus astigmatism, the eye, as we've shown, is much deeper, running through that steeper meridian. That means we're going to have greater lift, more tilt of the contact lens, and that hydraulic force isn't trapped in there to produce the effect that we need across that steeper meridian of the eye. So this is where a toric Ortho-K becomes helpful. When your symmetric lens is only landing across the horizontal or the flat meridian, but lifting so much across the vertical, putting 2 depths of axes into the lens allows much better peripheral alignment, better centration, and most likely better hydraulic force to achieve the target that we want. Now, when you're not sure about the fluorescein pattern, we discussed what are our options. And if we're not 100% comfortable with fluorescein analysis, what do? And it's very easy to say, is the pattern acceptable enough to dispense? And then let's rely on the post-treatment topography. So the subtractive map will tell us so many things. Do we have the treatment zone position that we desire? Do we have the treatment zone size that we desire? Do we have the lens position in the closed eye environment that we want? And then, are we achieving the refractive change? So we don't have to do a refraction post-treatment. We can just look at our topography to understand the amount of myopic shift that we've created. Now, when you do orthokeratology, it's helpful to know that you can really only do 4 things. You can get it right, we get a bullseye. You fit it slightly flat, we get a smiley face, we get a high riding treatment zone. You fit it steep, we create apical steepening, possibly associated with a little bit inferior decentration, we get the central island. You fit a really well constructed lens, but ever so slightly tight in the alignment zone, and it may ride a little bit low. We get what's called the Frowny face. The bullseye, smiley face, central island, and Frowny face were all described originally by John Mountford in Brisbane, Australia, to help all of us understand what is the effect of Ortho-K, what have we done, and what needs to be modified when we did it wrong. Now, part of the story is understanding the subtractive map. And John Mountford was one of the first to explain how to really use these maps to best appreciate the Ortho-K outcome. So what you do is you compare before Ortho-K to after Ortho-K. So pre-treatment pristine cornea compared to the post-treated orthokeratology topography. Then on the subtractive side, you get your subtraction or your difference or your comparison map. So we're comparing all 15,000 points of data subtracted from your post-treatment to give you the difference. Wherever you see blue, you flatten the cornea out. You've reduced the myopia. Wherever you see hot colors, you've steepened the cornea up. So what creates this blue treatment area? let's overlay a fluorescein pattern. And where the lens is close to the cornea, where the tear film is very thin, you create a compressive force pushing on the epithelium. Where you see this reservoir here, where you have a thick layer of fluid, you create a suction force. And that's what creates this yellow, orange, or hotter contour here. So the axial map describes for us where the treatment zone is, how big the treatment zone is. And when we click our cursor in the center, what the power change was. In this case, this patient had a 2 3/4 diopter shift in the power on the center of the visual axis. So there was a 2 3/4 diopter shift to the fovea. So axial for vision, for power, for treatment zone. Tangential to understand shape. So when we look at a tangential map, we're looking at this hot contour, this ring. Where is it in relationship with the pupil? So the tangential map describes for us where the lens was positioned when the patient was sleeping. Is that red ring centered to the pupil? If we were to overlay the fluorescein pattern, we see that that hot contour was constructed or created by the thick fluid layer, the reservoir that is trapped by the flat base curve and our steep reverse curve junction. So that's what gives us the suction force. And where that suction force is, that red ring or orange ring will tell us where our lens was positioned in the closed eye environment. So when you look at this outcome, what would you call it? Here's full treatment in Ortho-K. Is this a bullseye, central island, smiley face, frowny face? This is what you'd call your beautiful bullseye. We see this blue treatment area relatively well centered to the black pupil. We click our cursor in the center, and this patient had a 3.34 diopter RX change. So when you compare the power of the eye on the visual axis before Ortho-K to after Ortho-K, the subtractive map tells you the difference is a little over 3 1/4 diopters. So axial map is saying it's a bullseye. Let's go to the tangential map and let's focus on that red ring. Where is that red ring in relationship with the pupil? And you would argue that that red ring looks very well centered to the pupil. If anything, touching the superior pupil a little bit below down here. So if we were going to make any argument that it's not a perfect bullseye, we'd say it's slightly low. But otherwise, this is a beautiful effect. The bullseye means you did everything right. You got the sagittal depth correct. You got the alignment zone to cornea relationship correct. You've got a beautifully centered treatment and a nice myopic reduction. So the bullseye means our lens construction is really quite good for this cornea. Now, what about here? Would you call this bullseye, central island, smiley face, frowny face? And what we see is a blue treatment zone, a little bit low in relationship with our black pupil. We also show some central corneal steepening, and this is your classic central island. Normally, a true central island is associated with poor vision. So if the patient had a topographical central island, and with your spherical overrefraction, if the quality of vision was poor, then there's a real good chance that you've got a real island. We've steepened the cornea up. At times, when there's some central corneal staining, some of that mild grade 1 staining that we often see after one night in Ortho-K, the disruption in epithelium will create a disruption in the placido reflection, the ring reflection, and we get a false central island. So if the vision is improved, it's probably a false island, and you should just wait it out. Let that patient wear the lens a few more nights and confirm that you've got the bullseye. But if the vision is much poorer with the spherical overrefraction, if your best corrected VA is down quite low, then you know that that's a real island. Now, when we pull up the tangential map, look at that red ring. Where is it centered? And you notice that red ring low in relationship with the black pupil. And like any corneal GP lens, a low-riding lens is typically a steep lens. And the same thing is true with Ortho-K. Low-riding lens is a tight lens. So that's central island. So what creates a central island? Generally, it's too much sagittal depth. The lens is too far off the central cornea. We get a hydraulic suction force in the center rather than a compressive or push force that will flatten the central cornea. We actually steepen the central cornea. Another thing that can cause a central island is a tight alignment zone or the wrong diameter. A small lens on a big cornea, for instance, or a big lens on a small cornea. So check visible iris as well. But generally, if you're right in the correct diameter of lens and you have a central island, then reduce the sagittal depth. And if it's riding low, then loosen up the alignment zone. Combination of the two, lower sag and looser alignment, is usually the ticket to fix central islands. Now here's another response. Is it bullseye, central island, smiley face, frowny face? And here we see our classic smiley face. The lens riding high, the blue treatment zone high in relationship with the pupil, and we get this big paracentral smile, either inside the pupil or very near to the pupil, but associated with the blue treatment zone riding high. If we click our cursor in the center, this patient had about a 0.87 diopter RX change, and in this deeper area blue looks like about a 2 diopter RX change. So if this was a moderate or low myopia, this patient would probably be pretty happy with the treatment that we created, the myopia that we've reduced. However, central island patients often will report their vision fades very quickly in the afternoon, and at night they may notice more aberrations, more flare and glare. So centering the treatment is critical to creating a better outcome here. So smiley face is what the axial map is saying to us. Then let's go to the tangential map and look at that red ring. It's approximately a millimeter inside the pupil at 6 o'clock. It's at the pupil margin above. So that red ring is indicating our lens, or the suction forces of our lens, are applied to the cornea in a manner that appears toward the higher side. So this would be your smiley face. So smiley faces can be associated with inadequate depth, a lens that's too close to the cornea, that hits the central cornea, and the lens decenters up. So if you have central corneal staining from inadequate sagittal depth, we want to raise the sag height. We want to raise the lens off the center cornea. And normally the way to do that is steepen the reverse curve. So more sagittal depth, steepen the reverse curve by 0.1 millimeters. Now, if the cornea is clear, so this lens is not hitting the central cornea, but it's a smiley face outcome, then we may have an alignment zone too loose, or we have lid forces quite strong. And by tightening up the alignment zone, you neutralize those lid forces, we get a better centered effect. So smiley face, effectively a loose fitting lens or flat fitting lens. And again, similar to RGP lenses, a flat lens rides high, a steep lens rides low. Now the last outcome is this one. Bullseye, central island, smiley face, frowny face. Which one is this? And of course, this is your frowny face, where we have the beautiful blue treatment zone, but decentered low rather than high. So opposite of the smiley face, we have the frowny face. We have the steeper contour hitting the superior pupil, possibly inside the pupil. The axial map indicating we have 1.72 diopters RX change. So this patient might be relatively happy with their vision. The question would be, how is the patient toward the afternoon or the evening? Is this good enough, or can we better center it? Then we go to the tangential map and we look at that red ring. So again, tangential tells us where the lenses are positioned in the closed eye. And we look at that red ring in relationship with the black pupil, and this lens appears to be riding quite low. So your frowny face is generally an appropriate sagittal depth. It's almost a bullseye. It's almost a perfect fit, but the alignment zone is generally a little on the tight side. You might also look at the visible iris. Is your lens too big or too small for this eye that it's causing the decentration? So check visible iris diameter in relationship with your lens. Now, let's finish up with an example. And here's a patient with the baseline cornea and the post-treatment cornea. What if we didn't use the subtractive map? What if we were just trying to assess our outcome based on the one single post-treatment map? Do we have a bullseye, a central island, a smiley face, or a frowny face? What would be your call? Would you continue treatment? Would you discontinue and choose another lens for this patient? What would be the right diagnosis? Well, when we pull up a subtractive map, we see a central island. We also see a blue treatment zone that appears like it's well centered, maybe arguably a little on the high side. So we're seeing two things at work here, a central island and a blue treatment zone that looks relatively well centered, maybe a smiley face, maybe a little bit on the high side. So we're not 100% sure what's happening here. Let's pull up the tangential map. And what does the tangential map say for centration? We look at that red ring and it appears like it might be riding centered to maybe a little bit low. So it's important that you use the subtractive map to make your final call, because one single map by itself doesn't give you 100% of what you need to understand what's happened. The subtractive map tells you how things are different. And we look at the blue treatment zone here and say, well, it looks like it's positioning reasonably well. We look at the tangential map. It's decent, maybe a little bit low. So is it central island or smiley face? Well, this patient had a little bit of grade 1.5 central corneal staining after one night, and that produced a disruption in epithelium. So we got a disruption in the ring reflection. We got a false central island. So the call here would be to ensure that this cornea responds well within a half an hour or hour of post-treatment, that the epithelium recovers quickly. Then I would put them back in the same lens if the cornea is clear and ensure that we get the bullseye. So go more nights, because this is most likely not a central island. It might end up as a smiley face. It might creep up higher and higher, but at this point, both axial and tangential map are saying it's relatively well centered. So use your subtractive map. It's such a valuable function. And here's the same patient after a month of wear. That island has completely disappeared. The centration of the lens is quite good, a little bit temporal, but we've got 100% of the blue treatment area covering the pupil. We click our cursor in the center. This patient has almost a 2.5 diopter RX change. What would be the outcome here? If you didn't use a subtraction, what would you say the effect was? Here's our baseline. Here's our post-treatment. Is it bullseye? Is it central island? Is it smiley face? Is it frowny face? And looking at one single map by itself can be tricky. For instance, how big is the treatment zone? What is the treatment zone position? What is the RX change? All of these things we don't know because we're using only the post-treatment map. So here's your subtraction, and we would look at the blue treatment area and say that it's pretty well centered, maybe arguably a little bit high. So it's slightly smiley face, but again, this could be a very acceptable bullseye. We click our cursor. In the center, we have a 3 diopter refractive change. We look at the tangential map. It's confirming ever so slightly high, but if this patient's vision was very good and we had good AM to PM quality of vision, then I'd be utterly comfortable keeping this patient in the lens. Because it's slightly smiley face, we could tighten up the alignment zone by a small amount to try to bring the lens a little more onto center, especially if the patient were having some quality of vision troubles toward the PM. But again, this is a pretty well-centered response. So use your subtractive map. It's this wonderful function that every topographer has that allows you to compare before Ortho-K to after Ortho-K, and then you have your subtractive difference. So you understand the refractive change, the treatment zone position, the treatment zone size, the lens position in the closed eye environment. So in summary, make sure that you do good baseline corneal topography captures. Make sure that you get 100% of the cornea or as much as you possibly can, good quality reflection of the placido across the vast majority of the surface. When you see a displaced apex, don't be surprised if your Ortho-K lenses will similarly follow the natural eye displacement. When you have apical astigmatism, we can generally fit that patient in a symmetric lens. When we have limbus to limbus, we very often need a toric. And then use your subtractive maps to figure out, is your lens on, is it steep, or is it flat? Is it bullseye, central island, smiley face, or the final one, frowny face? Now, just to acknowledge Medmont for their sponsorship of this session. Why would you want to consider a Medmont? One of the features is the composite map feature that we discussed, where we're able to image 100% of the cornea. So for a large diameter like an Ortho-K lens at 11 millimeters, very important to have that peripheral corneal shape. Your maps can be converted to elevation, and from elevation, you can construct your GP lenses from the contact lens software. So you can model and optimize the fit of your GPs, your multifocal lenses, your toric RGPs from the Medmont contact lens software to optimize the fit. And then the first lens you order may be the last lens you need without exchanges. You can also drop scleral lenses onto the topographies to optimize the fit of the larger diameter as well. Now, placido imaging and the Medmont allow us to reflect the placido off the tear film and have an appreciation of dry eye. And the Medmont's been found to be very accurate at determining the threshold of dry eye, or specifically when there's tear film breakup. And then lastly, as we've seen and concentrated on so much in this session, the topographies both pre and post treatment with the Medmont help us to understand where to go with the initial lens, but also where did we go with the lens that we fit? What modifications are needed for us to best resolve any modifications that may be required or any problems with our Ortho-K treatment. So thank you very much for your time and listening to this session. Very much appreciated and hope you found it helpful.